Recording is in progress. All right, so like I said, we'll be going over chapter 24, Psychiatric Emergencies. This is going to be a short chapter, so I'm pretty sure we'll fly right through this. Please give me questions, comments, whatever you got as we go through, so we can make sure that everybody's got a clear understanding of what's going on. All right. So there's your National EMS Education Standard Competencies. Oh, what did everybody think about the gray shirts? I like the gray shirts. You see that they changed the colors to the gray t-shirts. Is that better? I thought it was pretty good. I like the gray. The gray works really well. Yeah. Yeah, the blue logo on the gray, it does look pretty good. At least it's not yellow. Yellow shirts. I don't know. I'm not even going to speculate. I probably do know. I do know, but that's okay. All right, let's rock and roll. Introduction. So AMTs are going to deal with patients that are undergoing psychological or behavioral crisis all the time. Even if it's, either it being acute or something that's a chronic illness, or if it happens while you're on scene working with them, everything was just fine until it wasn't fine kind of deal. It could be as a result of a medical condition, some sort of mental illness, or mind-altering substances, or stress even can cause it. Mr. Wade wants to be in this class so bad, he's in here twice. There's two Wades. All right, so myth and reality of psychological conditions. Everyone experiences an emotional crisis at some point in their life. Perfectly healthy people may have some symptoms and signs of mental illness from time to time. We all see it, and the stress factor, that we definitely see it. I'm sure we all saw it this past year, or all experienced it this past year at some point. Do not assume, though, that you have a mental health illness when you behave in ways that's going to be discussed in this chapter. Okay, so don't think just because we're sitting here and be like, oh, maybe I'm sick, and maybe I have some sort of illness, maybe I'm sick. I have a psychological issue. We all have them at some point or another. What we're going to be getting into is when you take and you amplify those psychological issues, and it becomes a health issue, right? So the most common misconception about mental illness is that if you're feeling bad or depressed, then you must be sick, okay? There are many justifiable reasons for feeling depressed, such as divorce, loss of a job, death of a relative or a friend. You got, sadness is a normal reaction to a crisis situation. If the problem is, if sadness becomes long-term, it may be an indication of a behavioral problem at that point, okay? So many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. Only a small percentage of folks with mental health problems fall into that category. Although you can't determine what has caused a person's crisis, you may be able to predict whether the person will become violent. So this is an important skill for you to know. So defining behavioral emergencies. Behavior is what you can see of a person's response to the environment, which is going to be his or her actions. Responses can be obvious or unclear. Most of the time, people respond to the environment in reasonable ways. There are times, however, when stress is so great that the normal ways of adjusting do not work. A person's behavior is likely to change even if it's only temporary. It is likely to change. The new behavior may not be appropriate or normal, though. So there is some disagreement over what behavioral is normal, and there's no clear idea or model of what normal is for behavior. What we do know, though, is that normal tends to vary amongst cultural or ethnic groups. So it's basically classified as what society is going to accept. If it's acceptable in the current society, then that's what is normal. Abnormal behavior is anything that deviates from society's norms and expectations. Okay. So this tends to interfere with a person's well-being and ability to function at that point. And if it becomes a problem from there, it could be harmful to the individual or the group as a whole. So a behavioral crisis or emergency is any reaction to events that interferes with the activities of daily living, or ADL, or has become unacceptable to the patient, family, or the community. For example, if the interruption of daily routine tends to recur on a regular basis, the behavior is also considered a mental health problem. It is then that it's a pattern rather than an isolated incident. And then all isolated means is that it's a short-term incident or a short-term incidents that are normal. Okay. So usually if an abnormal or disturbing pattern of behavior lasts for at least a month, it's a matter of concern for mental illness from a mental illness standpoint or a mental health standpoint. So chronic depression is a medical diagnosis of a persistent feeling of sadness, despair, and discouragement. This type of problem would be considered a mental health disorder. Okay. So a person who is no longer able to respond appropriately to the environment may be having what is called a psychological or psychiatric emergency. When a psychiatric emergency happens, the patient might show agitation or violence or become a threat to himself or herself or others at that point. Psychiatric emergencies they're more serious than typical behavioral emergencies. So an immediate threat to the person involved or to others in the immediate area should be considered a psychiatric emergency. Not all major life disruptions have to involve violent behavior. Just know that. Disruption can take many forms. Not all involve violence, nor are they all psychiatric emergencies. All right, so the magnitude of mental health problems. According to the National Institute of Mental Health, at one time or another, 1 in 5 Americans has some type of mental disorder. 1 in 5. So a mental disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. It can be caused by social, psychological, genetic, physical, chemical, or biological disturbance. If you look in your book, Common Causes of Behavioral Alterations, are listed in table 24-1, 24-1. So pathophysiology of abnormal behavior. Any of the following can produce behavioral emergencies, abnormal behavior, or an altered mental status. So take a look at those below. So an AMT is not responsible for diagnosing the underlying cause of a behavioral crisis or a psychiatric emergency. It's not your job. There are two basic categories of diagnosis a physician will use. You have organic, which is physical, and then you have functional, which is psychological. Organic causes of behavioral emergencies, organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychological functioning of the brain tissue. So some of these causes are going to include sudden illness, recent trauma to the head, seizure disorders, drug and alcohol intoxication, overdose or withdrawal of that, diseases of the brain such as Alzheimer's disease and meningitis also. So altered mental status can arise from low level of blood glucose, like we've talked about, lack of oxygen, hypoxia, right? Inadequate blood flow to the brain, so improper perfusion, excessive heat or cold. And then altered mental status is a change in the way a person thinks or behaves. Also, it's just a change in the way they think or behave. It could be an indicator of a psychiatric disease such as bipolar disorder, or it could be an indicator of an acute medical illness. So recognizing a medical illness could help save that person potentially. So environmental causes. A person's environment, psychosocial and sociocultural exerts a tremendous influence on their behavior, right? When people are constantly exposed to stressful psychosocial events or what we would call developmental influences, they may develop abnormal reactions. So when a person's basic needs are threatened, that individual faces a crisis. A person in crisis has two alternatives for dealing with this threat. They can either cope with it by finding ways to alter the situation or the individual's perception of it so that the threat is no longer so stressful, or they can attempt to alleviate the discomfort by escaping from the stress. Sociocultural factors directly affect biology, behavior, and responses to the stress of emergencies. All right, up next you have injury and illness as causes. That's acute illness can cause abnormal behaviors, we all know. An acute traumatic situation creates a great deal of stress for a person experiencing the trauma as well as those around the individual. So we have what's called post-traumatic stress disorder, or PTSD. That's a severe form of anxiety that stems from a traumatic experience. All right, so up next we have substance-related causes. That could stem from the use of alcohol, cigarettes, illicit drugs, and other substances that change the way a person feels, behaves, or even thinks. So functional disorders. A functional disorder is one in which the etiology cannot be traced to an obvious change in the actual structure or physiology of the brain itself. Okay. So something is going wrong but the root cause cannot be identified as a brain dysfunction. An example of psychiatric disorder include things like schizophrenia, anxiety conditions, and depression. All right, so psychiatric signs and symptoms. Physical symptoms and signs reflect the body's attempt to maintain its balance in the face of physical stress. When a person's mental health is challenged, similar psychological mechanisms or behaviors are mobilized to help return the person's mental state to homeostasis. Psychiatric symptoms and signs can be grouped according to the symptoms they affect. The psychological functions involved are consciousness, thought, affect, memory, orientation, and perception. Psychiatric signs and symptoms can affect consciousness, motor activity, speech, thinking, mood, and affect memory, orientation, perception, and intelligence. So if you look in your book, the signs and symptoms to those disorders are going to be listed in table 24-2. 24-2. All right, so let's get ready to size this patient up. Let's get ready to do a patient assessment with this. So first off, you're going to do a scene size up. The assessment of the environment can give us clues to the patient's condition or the cause of the emergency, right? Scene safety is going to be of the utmost. All regular AMT skills are going to be used in behavior emergencies. Other management techniques may also be necessary. So to ensure your safety, make sure that you follow a list of guidelines that you have. Determine the mechanism of injury and nature of illness. Your primary survey is coming up. You're going to form a general impression. First, consider your safety. Then determine how the patient is responding to the environment. In this situation, unduly dangerous to you and your patient is the situation unduly dangerous to you and your partner? And if it is, what do you need to do? So if you need immediate law enforcement backup, say so. Call it in. Does the patient's behavior seem typical or normal given these circumstances? For example, a patient who has just been assaulted has a good reason to be fearful, even of you. Respect the patient's territory and limit touching without permission. You want to make sure you limit that. So you're going to approach that patient slowly and purposefully, avoiding the threatening actions, statements, and questions. You're going to avoid all of that. You're going to assess the pupils first. So this may indicate other causes of altered mental status. A behavioral crisis puts tremendous stress on a person's coping mechanisms also. The person's actually incapable of responding reasonably to the demands of the environment. It may be temporary, as in an acute illness, right? It may be longer lived, as in a complex chronic mental illness. In either, the patient's perception of reality could be compromised. So limit the number of people around the patient when performing your assessment. Stay alert to any potential dangers. So because a patient that's in unstable condition may become very violent at any time. So you're going to watch, in doing so, you're going to watch for agitation and aggression. You may want to separate the patient from bystanders or family members who seem to be exacerbating the patient's condition. Before beginning your primary assessment, you may you may ask the patient to step into another room and speak to your partner, or you may take the patient to the ambulance. So as I said earlier, violent patients make up only a small percentage of those that are undergoing a behavioral psychiatric crisis. However, the potential for violence should always be an important consideration. There is no correlation at all between the size of the patient and the potential for violence. Just remember that. The small ones will whoop your ass just as bad. So assess the level of danger using these using the risk factors. So one of the things you're going to look at is the history. Has the patient previously exhibited hostile, overly aggressive, or violent behavior? Look at the posture. So how's the patient sitting or standing? Is the patient tense, rigid, or sitting on the edge of the seat? Could this be a warning signal of impending hostility if you see that? Look at the scene. Is the patient holding or near potential lethal objects? Also, you're going to note any conventional household objects that the patient could use as weapons, such as lamps or heavy dishes. I had a patient one time that used a candlestick on her son. And I'm talking about, this was a stout candlestick. This one, it was like a candle brick instead of a candlestick. He had punched his mother, and then had called the ambulance whenever she retaliated and hit him with this candlestick. One of the things that was interesting was that when I asked him, hey, what happened here? He said that she hit me with a sharp, blunt object. Thought that was odd, but I digress. So also you're going to look at vocal activity. What kind of speech is the patient using? Is the patient using loud, obscene, erratic, and bizarre speech patterns? Usually indicate emotional distress. Is someone using quiet, ordered speech and is not as likely to strike out, but still might? You got to worry about the quiet ones. What you're going to look at too is physical activity. The patient's motor activity may be the most telling factor of all. So carefully watch the patient with tense muscles, clenched fists, glaring eyes, or the patient who is pacing, can't sit still, or is fiercely protecting their personal space. So agitation may predict a quick escalation to any type of violence that may be coming. So also consider these factors in assessing a potential for violence. So poor impulse control, a history of truancy, fighting, an uncontrollable temper, low socioeconomic status, which, unstable family structure or an inability to keep a steady job. That should go with with a notation that violence occurs in all classes, and socioeconomic class is relatively based on geographic area. So some other things you're going to look at is you're going to look at tattoos, especially those with gang identification, with statements such as born to kill or born to lose. Those could be indicators. So those tattoos that may be jail related, they tend to be homemade and on hands and forearms. You're going to be looking at substance abuse, depression, which accounts for 20% of violent attacks. Take a look also at functional disorder. If the patient says that voices are telling him or her to kill, you better believe it. You better believe it. So also consider these, because these are pretty important. Airway and breathing. Determine if a life-threatening medical condition exists. If your patient is in physical distress, assess the airway, make sure it's patent and adequate. Evaluate the patient's breathing, and then provide appropriate interventions based on your assessment findings from there. Observe for signs of overt behavior and give close attention to body language. You want to note any evidence of rage, elation, hostility, depression, fear, anger, anxiety, confusion, or any other type of abnormal behavior. So also, you want to talk to the patient as you continue your assessment. Always talk to your patient, right? And explain every procedure that you intend to perform. Up next, you're going to check out the circulation. So you're going to assess the pulse rate, the quality, and the rhythm. You're going to obtain systolic and diastolic blood pressures whenever it's possible, if it's possible. Evaluate for the presence of shock or bleeding. Also, assess the patient's perfusion by evaluating the skin color, temperature, and condition. And then lastly here, you got transport decision. So transport decision. Unless your patient is unstable from a medical problem or trauma, prepare to spend time at the scene with this patient. So depending on your local protocol, there may be a specific facility to which the patient with mental problems are transported. I don't have my wife here today to make me a good cup of coffee, so I'm gonna be all sleepy. I got too many toys around me to play with. So I got a little flashlight. Be distracting me too. Everybody hanging in there so far? We know this stuff is awesome. All right, so history taken. Actually, let's see here. We'll finish history taking, then we'll take a break. So history taking, investigate chief complaint. Once any life-threatening emergencies have been addressed, remove the patient from the crisis or the disturbing situation. Focus your questions on immediate problem to avoid confusion. Establishing a good rapport with that patient is going to enable you to provide better care for that patient. Use the therapeutic interviewing techniques that we've talked about in the past. Limit physical contact to minimize patient's apprehension. You want to avoid using any type of threatening actions or statements or questions like that. We should be well known for that, or well aware of that. Approach the patient slowly and purposefully when you come up to that patient. Don't run up on him. You want to evaluate the potential for suicide or harm to others in all of these patients. So factors that increase the risk include recent depression, recent loss of a family member or a friend, financial setbacks, drug abuse, or evidence of a detailed plan. So a patient who has a detailed plan and access for means to complete it is likely to carry out the plan. Something else you want to do is utilize surrounding people. So family, friends, and observers may be a great help answering patient history questions. The primary goals of this assessment are recognizing major threats to life and reducing the stress of the situation as much as possible. Mental health professionals frequently use reflective listening, also called active listening. It involves repeating back to patients what they have said, encouraging them to expand on their thoughts. It often requires more time than is available in the EMS setting, but it could be a helpful tool when other communication techniques are unsuccessful. So I'll tell you this, I use this on people that aren't I use it at home. even, which my wife now, she says, "Are you using that crap on me?" She says it all the time. So what I call it is mirroring. We call it mirroring. We do the same thing on the radios all the time. Dispatch does it all the time, or they should be doing it all the time. So in mirroring, whenever you're speaking to me, you'll tell me something, and I'm listening to you. I'm not looking around, playing with my crap, writing on the or typing on the computer, banging the computer away. I'm looking at you. I'm interacting with you. I'm showing you that I'm listening. And so you'll say something to me, and then I'll repeat the last three, the last 3 or 4 words that you say. And that's it. The last 3 or 4 words. And it all depends on your attitude as well, or your voice, how you project your voice. So something that I use is whenever I'm trying to do questions or what have you, is I'll do something called the late night DJ voice. And so you bring your voice down and you talk to that patient. And then when they're speaking, all your questions you make open ended or what have you, so that they speak to you. And then you repeat the last 3 words that they say every now and then. Something else that you can do is you can employ labeling. So let's say that the patient tells you that it's been really hard at work. Their hours have been cut. Or they've been working way too much. It's been very stressful. They don't get paid enough for what they do, so on and so forth. So when you start labeling that patient, you're labeling their problems. One thing that you don't do is relate it to yourself. You want to stay in your patient's realm. You want to talk about your patient, not about you. So avoid saying things like, "I think that," or "I feel like," or "I know that." That it's not about you. It's about that patient. So what you say is, "It sounds like you've been handling a lot of stress lately. It sounds like there's been some issues at work, possibly." And it allows them to speak, gives them the chance to talk. And it makes them know that you are listening to what they have to say. And that's going to be an active listening experience. Makes sense? I could talk days about this. We could talk about tactical empathy. We could talk about all this other stuff. Make what interesting? All right. So, I said we'd take a break. Let's take a 10-minute break from here. See if I can even find my my 10-minute timer. Oh yeah. All right. 10 minutes. See that on the phone there? That was me doing a fire alarm. That was a fire alarm. That was a supervisory fire alarm. All right. Can everybody see the screen again? Okie dokie. All right, secondary assessment. So physical examinations. Whereas much of your assessment involves interviewing the patient about any psychiatric history, also look for signs of organic cause of the patient's behavior as well. So obtain the vital signs to look for signs of fever or indications of increased intracranial pressure. Examine the skin temperature and moisture and note any prominent tattoos. Certain tattoos may suggest a tendency towards violence. Scars may indicate self-mutilation as well. I don't know what their aversion is with tattoos. Inspect the head for evidence of trauma. Check the pupils for size, equality, and reaction to light. So looking for that perla, right? Pupillary abnormalities may indicate a toxic ingestion or an intracranial process as the source of a patient's behavior. So you're going to note any unusual odors on the patient's breath, such as poisons, alcohol, ketones from a possible diabetic ketoacidosis. Examine the extremities. Look for needle track marks, tremors, and unilateral weakness or loss of sensation, possibly. Unless a significant trauma problem exists, a secondary assessment may be conducted to provide helpful information. Maybe. So on the basis of your transport time and the patient's mental status, the secondary assessment may be deferred for your psychological emergencies. Vital signs. Obtaining vital signs will not exacerbate your patient's emotional distress. But you have to explain what you're doing, right? Informative. Make every effort to assess the blood pressure, pulse, respiration, skin, and pupils. Remember that a behavioral crisis can be caused or precipitated by a psychological problem such as head injuries, diabetic disorders. It can aggravate a pre-existing condition. So remember the physical person and the emotional person are one and the same. So reassessment, interventions. Reassessment is routinely performed during the transport. This is a good time to assess more details of your patient's mental status. Often patients with abnormal behavior may have settled down physically, but their minds may still be in a state of flux, right? So this could lead to very impulsive behavior. So watch yourself. Monitor a patient's, I'm sorry. You want to make sure that you're monitoring your patients vigilantly. for sudden changes in thought or behavior, particularly as you near the hospital. If the patients do not want help, they may try to jump from the ambulance or hurt themselves. So we've had a few try to jump from or have succeeded in jumping from an ambulance. If the patients will not hesitate to hurt you while attempting to exit the vehicle either. Yeah. So medical and traumatic conditions may cause deterioration in a condition identified earlier in the assessment. So that's why you want to make sure that you're constantly reassessing. So in your communication and your documentation, you want to try to give the receiving hospital advanced warning that a patient experiencing a psychiatric emergency is arriving. So you may want to say, you have a psychiatric emergency, suicidal ideations, suicidal, suicide attempt versus ideations, know the difference. Many hospitals require extra prep to ensure that the appropriate hospital staff in the rooms are available. So report whether restraints will be required when the patient arrives at the hospital as well. Document thoroughly and carefully. To describe a confusing scene as clearly as possible, think about what you are going to write before you actually write it, because you have to make the confusing scene make sense. So yours may be the only documentation about the patient's distress. Okay. Psychiatric emergencies are fraught with legal dangers, so document everything that occurred on a call, especially situations that require restraints. If restraints are used, say what type and why they were used. All right. So emergency medical care. Treat the patient with a psychiatric problem by following the approach stressed throughout this chapter. Maintain safety for your patient and yourself. Place the patient on the stretcher with the straps in place, okay? You are in more control of the situation if it turns violent at that point. So restrain violent patients if it's needed. Restrain them. Don't let it be a continual problem. Remain with the patient at all times. Don't let them out of your sight. The only time you want to leave them is if it's an unsafe situation starts to exist. Then leave them, but don't come right back. Law enforcement needs to be involved if that's the case. Avoid challenging the patient's personal space. So you always want to ask permission to touch the patient. Explain your procedures before you perform them. So the why behind the what we're doing. Attempt to eliminate or decrease anything that may distress the patient. So avoid performing inner procedures that are not absolutely pertinent. So you may not need an IV on this guy. You may not. Is it pertinent? Do you need it? Do you need to be poking and prodding if you don't need to necessarily? So avoid being judgmental. It may be hard to do, but as you start to do this more, you'll lose that. You won't lose the judgment. You'll probably be more judgy. You'll just know how to hide it better. The patients where I'm getting at is that they didn't ask for this problem, and view it as any other type of illness that you may come across. If there's any reason to suspect that a patient may have taken something, bring any drugs found to the medical facility. All right, so assessment management of specific emergencies. So acute psychosis. Psychosis is a state of delusion in which a person is out of touch with reality. To the person experiencing a psychotic episode, the line between reality and fantasy is blurred. The patient may be belligerent and angry or silent and withdrawn. Never know. So the causes of a psychotic episode are going to include the use of mind-altering substances, intense stress, delusional disorders, schizophrenia. Some episodes can last for brief periods. Others can last for a lifetime. Disorganization and disorientation are ways in which various conditions such as schizophrenia and organic brain syndromes may present themselves. All right, so schizophrenia. Schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences thought to contribute to the disorder include things like brain damage, genetics, psychological and social influences. So people with schizophrenia experience symptoms that include delusions, hallucinations, a lack of interest and pleasure, or even erratic speech. So your assessment of psychosis, patients are usually incoherent and rambling in their speech. A thorough examination of the patient is rarely possible. Principal objective for the EMTs is to transport the patient to the hospital in an atraumatic fashion. Got it? Atraumatic. So something that you may want to think about, another mnemonic to put in your toolbox, is what we call COAST map. COASTMAP. COASTMO. I'm sorry. COASTMAP. COAST map. So the COAST map mnemonic is one way to remember the signs and symptoms commonly associated with patients experiencing a psychotic episode. So the C stands for consciousness. Is the patient's level of consciousness, if the patient's level of consciousness fluctuates, suspect an organic brain syndrome. O is going to be disturbances in orientation. Okay, orientation, O. So that's going to be disturbances orientation are more common in organic disorders than in psychoses. All right, A stands for activity. It's most commonly accelerated with agitation and hyperactivity, but it may also be diminished. S stands for speech. It may be pressured or sound strange because of unusual words that the patient has invented. T stands for thought. So the thought is disturbed in progression and content and may show any of the following disorders. You have flight of ideas, where with the patient's mind plunging from one thought to another. You have loosening of associations, delusions, especially of persecution. You have thought broadcasting, or thought insertion, and thought withdrawal. Okay. So up next is memory, M, memory. It can be relatively or entirely intact in psychosis. Up next is going to be affect and mood. Affect, affect, and mood. So mood is likely to be disturbed in psychosis. The mood is. And then P, which is going to be perception. So if there's auditory hallucinations or auditory hallucinations are going to be common in psychosis as well. Perception. All right, so the management of psychosis. The unusual methods of reasoning with a patient are unlikely to be effective. Okay. Use your uncomfortable feelings. Use your uncomfortable feelings to help make a tentative diagnosis. The disorganized patient needs structure. Remember that. You should. What was the after flight, or what was after flight of ideas before thought brought? Oh my goodness. So so flight of ideas is where the patient's mind plunges from one thought to another. You also have loosening of associations. You have delusions, especially of persecution. You have thought broadcasting, and then thought insertion and thought withdrawal. Is that what you're talking about? Anything else? Okay. All right. So like I was saying, the disorganized patient is going to need structure. You should explain in plain language what is being done and what the patient's role will be in getting these things done. Direction should be simple, consistent, and firm. So make sure that you're putting out there firmly. Don't check up. The key is to keep orienting the patient to time, place, and the people in the environment. You want to reassure the patient and point out landmarks to help orient the patient. So some things that you may want to look at, because we don't have these type of drugs, is what we call non-pharmacologic techniques. They should be adopted. They should be adopted for this. So non-pharmacologic techniques. Look them up. So you may want to consider paramedic backup for the administration of a sedative or anti-anxiety drug if the patient is not compliant and possibly presents a danger to themselves or others. All right, so let's talk about suicide. So depression is the most significant factor that contributes to suicide. Anytime you encounter an emotionally depressed patient, consider the possibility of suicide. It is a common misconception that people who threaten suicide never commit it. A suicide threat or an attempt is a cry for help. Threatening suicide is an indication that someone is in a crisis that he or she cannot handle alone. And because of this, immediate intervention is going to be necessary for that. So you want to be alert to the warning signs, such as does the patient have an air of tearfulness, sadness, deep despair, or hopelessness that suggests any type of depression? Does the patient avoid eye contact, speak slowly or haltingly, and project a sense of vacancy in their voice or in their demeanor? So does the patient seem unable to talk about the future? Ask the patient whether he or she has vacation plans. Is there any suggestion of suicide? Even vague suggestion should not be taken lightly. Even if it's presented as a joke, you shouldn't take it lightly. If you suspect suicide as a possibility, do not hesitate to bring it up. Ask. Sometimes just coming right out and asking. So does the patient have any specific plans relating to death? Some examples of that would be like a patient they recently prepared a will or given away significant possessions. That can be some things. So consider the following risks that I'm fixing to tell you for risk factors for suicide. Are there any unsafe objects in the patient's hands or nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Is there any underlying medical problems? Remember, a suicidal patient may be homicidal as well. So be careful. If you believe that you're in danger, obtain law enforcement intervention as quickly as possible. In the meantime, try not to frighten the patient or make him or her suspicious of you the best you can. All right, up next, we're going to talk about agitated delirium. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. So agitation is characterized by restless and irregular physical activity. Although patients experiencing delirium are generally not dangerous, if they exhibit agitated behavior, they may strike out irrationally. And in such of these cases, your personal safety needs to be considered for this reason. So symptoms may include hyperactive and irrational behavior with inattentiveness and vivid hallucinations. Physical symptoms include hypertension, tachycardia, diaphoresis, and dilated pupils. Hallucinations are erroneous perceptions of reality. A patient may see you as a threat. Okay. Agitation is a biologic attempt to release nervous tension. It can result in sudden, unpredictable physical actions. If you think you can safely approach the patient, be calm, supportive, and be empathetic. Be an active listener. Nod, indicate understanding, limit your interruptions of your patient's comments. Just shut up and listen. Shut up and listen to your patient. You want to approach that patient slowly and purposefully and respect that patient's territory. You're going to limit the physical contact as much as possible. Don't leave the patient unattended unless the situation becomes unsafe. You're going to be careful interviewing you're going to use careful interviewing to assess the patient's cognitive function. You're going to try to indirectly determine the patient's orientation, their memory, their concentration, their judgment. So you're going to ask simple questions such as, when did you first begin to notice these feelings? Try to determine what the patient is thinking. For example, are his or her thoughts disorganized? Pay particular attention to the patient's ability to communicate clearly and make notes on the patient's apparent mood. You want to also pay attention to the patient's appearance, their dress, and personal hygiene. If you determine that the patient requires restraint because he or she is a threat to himself or herself or others, make sure you have adequate, well-trained personnel available to help you before approaching the patient, because it will, it's like trying to jump a bull. If the patient appears to be experiencing an overdose, take all medication bottles and illegal substance with you. to the medical facility. Make sure that the popo knows. So the patient should be transported to a hospital with a psychiatric facility, preferably. And whenever possible, refrain from using lights and sirens. You don't want to have a freak out. All right, up next is mood disorders. So mood disorders are among the most prevalent mental disorders. Up to 21% of the US population will experience a mood disorder such as a manic depressive illness or a major depression at some point in their lives. So the changes in effect are accompanied by other symptoms, and the net effect is to cause a major disturbance in a person's ability to function. So patients who experience either depression or mania have a unipolar mood disorder. Patients who alternate between mania and depression have a bipolar mood disorder. So manic behavior. So mania is one of the most striking psychiatric conditions. People experiencing mania typically have abnormal, exaggerated happiness, joy, or euphoria with hyperactivity and insomnia. Patients experiencing mania are typically awake and alert, but are easily distracted. So we talked about flights of ideas and delusions of grandeur make it difficult for them to focus on one thing. So some patients may report that their thoughts are racing. Their monologues may skip rapidly from one topic to another. Their memory is usually intact, but may be distorted by underlying delusions. A person having acute manic disorder or episode may show psychotic symptoms such as hallucinations as well. People experiencing acute manic episodes have a high probability of getting themselves into trouble in one way or another. So because patients with mania are unlikely to consider themselves ill, they may not agree that they need treatment. So depression. It's the leading cause of disability in people between the ages of 15 and 44 years of age. It affects women more frequently than men and may occur at any age. So it's readily identified by sad expression, bouts of crying, and listless or apathetic behavior. It may occur in episodes with a sudden onset and a limited duration as well. When a person experiences signs and symptoms of depression for more days than not for a period of at least 2 years, he or she may be experiencing a chronic form of depression known as dysthymic disorder. The diagnostic features of depression are most easily remembered by the mnemonic gas pipes. Gas pipes, GASPIPES. So you have guilt, you have for G, appetite is abnormal. S is sleep disturbance, usually takes the form of insomnia. P is paying attention. Patients with depression has an impaired ability to concentrate. I is going to be interest. So the patient with depression loses interest in things that were once important to them. P is psychomotor abnormalities. Can be increased from agitation or slowed. E is energy. People with depression have no energy, no energy. S is suicidal thoughts. All right, up next is neurotic disorders. So a collection of mental disorders without psychotic symptoms and lacking the intense psychopathology of other mood disorders. Treating neurotic disorders comes at a substantial price. Anxiety disorders are mental disorders in which the dominant moods are fear and apprehension. So you may have generalized anxiety disorder. If a person worries about everything for no particular reason, the person may be experiencing generalized anxiety disorder, or GAD. GAD. Patients experiencing GAD are often treated with both pharmacologic agents and counseling. All right, phobias. So phobic disorders involve an unreasonable fear. It's an unreasonable fear or apprehension or a dread of a specific situation or thing. The patient with a simple phobia focuses all of his or her anxieties onto one class of objects or situations, right? When confronted with the feared object or situation, the person with the phobia experiences intolerable anxiety and all of the autonomic symptoms that anxiety brings with it. So you want to explain each step of treatment in detail before you carry it out. You don't want to get to the step of treatment and it just become intolerable and then you can't get anything done. All right, so panic disorder. It's characterized by a sudden, usually unexpected and overwhelming feelings of fear and dread, accompanied by a variety of other types of symptoms as well. So women are more likely to be affected by this condition than are men, okay? Most affected people can identify a stressful event that preceded their first attack. The fear of going into public places is called agoraphobia, for one. All right. They can wait. So, medical legal considerations. The medical and legal considerations are more complicated when a patient undergoing a behavioral crisis or psychiatric emergency or whenever that's happening. Legal problems are reduced when the patient consents to care. So gaining the patient's confidence is going to be crucial in these factors. So mental incapacity can take many forms, including unresponsiveness. So as a result of hypoxia, drugs, or hypoglycemia, temporary but severe stress, depression. Once you've determined that the patient has impaired mental capacity, you got to then decide whether he or she requires immediate emergency medical care. So a patient in a mentally unstable condition may resist your attempt to provide that care. Do not leave the patient alone. Doing so may expose you to civil action for abandonment or negligence if something happens. In such situations like that, request law enforcement personnel to handle the patient. I know in the state of Mississippi, they have CIT officers. Always, when you have that behavioral patient, request one. The CIT officers actually have a little more leeway with behavioral patients than some ambulance companies and other law enforcement. So you're going to do that. So consent. Implied consent, as you know, is assumed with a patient who is not mentally competent to grant consent for emergency medical care. For example, the consent of an unresponsive patient is implied. The law refers to this as the emergency doctrine, right? Y'all remember this from chapter 1. The emergency doctrine, consent is implied because of the necessity for emergency treatment. So in a situation that is not immediately life-threatening, emergency medical care or transportation may be delayed until the proper consent is obtained. So in any form, you should do what? Contact your med control or follow your local protocols when in doubt. Remember chapter 1 stuff. Consent matters are not always clear-cut in psychiatric emergencies. So some things you're looking for is, does a life-threatening emergency exist or not? And if you're not sure, request the assistance of law enforcement personnel. That's important. All right, so limited legal authority. The AMT has limited legal authority to require or force a patient to undergo emergency care when no life-threatening emergency exists. So patients have the right to refuse care. However, most states have legal statutes regarding the emergency care of mentally ill and drug-impaired people. These statutes permit law enforcement personnel to place such a person in protective custody so that emergency care can be provided. Medical direction may also order transport of a patient against his or her will. So that means you'll be contacting who? Medical direction, or online direction. All right, so these provisions, or offline, or whatever you want to call it. So these provisions may vary, so you should be familiar with your local and state laws regarding these situations. The general rule of law is that a competent adult has the right to refuse treatment, even if life-saving care is involved. In psychiatric cases, however, a court of law would probably consider your actions in providing life-saving care to be appropriate, particularly if you have a reasonable belief that the patient would harm himself or herself or others without your intervention. Additionally, a patient in any way impaired, whether by mental illness, medical condition, or intoxication, may not be considered competent to refuse treatment or transport. Let me repeat for some of these ambulance workers that I have dealt with. A patient that is impaired in any way, whether by mental illness, medical condition, or intoxication, may not be considered competent to refuse treatment or transportation. Say it loud for the back. So these situations are going to be the most perilous that you'll encounter from a legal standpoint, yes. When in doubt, you're going to call your supervisor, the police, or med control, right? You're always going to err on the side of treatment and transport. It's far easier to defend yourself against the charges of battery than it is to justify abandonment. And I could name a whole handful right off the top of my head that have done it. Aggravates the piss out of me. All right, so restraints. No, if you're drunk, you're incompetent. Medically, legally, everything. You are incompetent. You cannot make decisions for yourself in a competent manner if you are drunk. And we run into that quite often. Now, law enforcement can help along, help them make that decision. You either ride with me or ride with them, so long as there's no life threat. All right, so restraint. Ordinarily, a restraint of a person must be ordered by a physician, a court, or a law enforcement officer. If you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit and to personal danger as well. Yeah. So legal actions against you can involve charges of assault, battery, false imprisonment, violation of civil rights. There's quite a list there. You may use restraints only to protect yourself or others from bodily harm, or to prevent the patient from causing injury to him or herself. You may also only use reasonable force as necessary to control the patient also. So different courts are going to define this differently. So always consult your med control and contact law enforcement personnel to help before restraining any patient. So you want to routinely involve law enforcement personnel if you're called to assist a patient in a severe behavioral or psychiatric crisis. So law enforcement personnel, they'll provide physical backup in managing the patient, serve as a necessary witness, and provide legal authority if restraint becomes necessary at that point. A patient who is restrained by law enforcement personnel is in their custody. Okay, so remember that. Always try to transport a disturbed patient without restraints if possible, though. So be aware of your standard precautions. If the patient is spitting, place a surgical mask on his or her mouth. At least 4 people should be present to carry out a restraint, each being responsible for one extremity, right? Before you begin, discuss the plan of action. You're gonna make sure that you talk this out. Who's grabbing what. You want to stay outside the patient's range of motion as you prepare to restrain him or her. And in subduing a disturbed patient, use the minimal force necessary. So you want to avoid acts of physical force that may cause injury to a patient. The level of force will vary depending on some of the factors, like the degree of force that is necessary to keep the patient from injuring him or herself and or others. A patient's sex, size, strength, and mental status, the type of abnormal behavior the patient is exhibiting. You want to secure the patient's extremities with approved equipment. Someone, preferably you or your partner, should talk to the patient through the process. Treat the patient with dignity and respect at all times. Monitor the patient for vomiting, airway obstruction, and cardiovascular stability. Never place your patient face down. Never place them face down. Do not place restraints in such a way that the patient's respirations could be compromised. And then reassess airway and breathing each time. Yeah. Yep. I think I saw a little snippet on it earlier. You want to explain the Elijah McClain case to the rest of the group? Kind of give them an idea. Yeah, so that is strictly dependent on your protocols. A lot of times we do not want to go pharmacologic on these, and Benadryl is not really considered a restraint type drug, or something that we would use for behavioral issues. It's great for kids, but we generally don't use Benadryl for that type of call. That person needs some sort of antipsychotic. Yeah. So they were saying, what he did was, they reported a suspicious person, and this person was supposed to be in a ski mask in this store, right? And then so when the officers confronted McClain, who was not armed, by the way, when they confronted McClain, he was not armed and he had not committed any type of crime. And they said that he resisted arrest, but I don't know what he was getting arrested for. So it was about 15 minutes. They tackled the guy on the ground and put him in what's called the carotid hold, and then called first responders, at which point injected him with ketamine. During that time, he had a heart attack on the way to the hospital and died days later after being declared brain dead. So the family is saying that law enforcement, that they used excessive force on him. No, so ketamine can be used, but there are other things. It was the way in which they did it. So it's were they doing it in the fact that they were holding this guy down? They're holding him in this position. They're restraining him, and then they use the ketamine. What was the issue with the ketamine? I don't know at this point. Has it been used for that? Yes. I'm sitting here trying to think of what we used to use Valium and there's another one, not Ativan. Haldol. Valium and Haldol is what we used to use, but those are specifically what we use for antipsychotics. And there's a certain way that you have to administer it at a certain time, and then there's things that you watch for during that if they need it. What was their assessment? If they're sitting there holding this cat down, what is their assessment of this patient? I think it may have also had something to do with, yeah. So I think it may have also had something to do with while they're wrestling this patient or wrestling with this patient, somebody jacked him. Yeah. So why not why not try to sedate him? I think like I said, I think the fact of the matter was the manner in which it happened. The manner in which it happened. And all the other surrounding. Now, if he would have been what was the issue? What was the crux of the issue? Was he a psych patient? Was he a psych patient? Or was he somebody resisting arrest? He hadn't committed a crime or anything else. At what point are you treating a psych patient, or are you calling was he a psych patient or was he a criminal? I think that was some of the issue with it as well. They said they used excessive force. They deemed it as excessive force. Yeah, they were all indicted. Yeah. For criminally negligent homicide. Well, it's going to be difficult to do now. All right. So let's talk about post-traumatic stress disorder and returning combat veterans. Yeah. I think it's got everything to do, though. We don't know what their documentation was. We don't know what their process was, what their protocols are. If they did contact med control beforehand, if they needed to, do they have a standing order for it? I don't know all of the instances. I just know the bare base of what happened. So other than talking about the bare base of what happened, I can't speak intelligently about what these ins and outs of the situation were. So post-traumatic stress disorder and returning combat veterans. So PTSD can occur after exposure to an injury from from exposure to or injury from a post-traumatic event. The reaction could be trauma that occurred long ago, or it may be the result of multiple traumatic events over time. It is not necessarily the result of one isolated or recent event. So it's estimated that 7 to 8% of the general population will experience PTSD at some point in their lives. So some signs and symptoms of PTSD are feelings of helplessness, anxiety, anger, or fear. That's the wife. So people with PTSD may avoid things that remind them of the trauma. The sympathetic nervous system provides the fight or flight response as a means to protect us in perceived dangerous situations. So, what? Hey, hold on one second. Sorry. So there's some of your signs and symptoms for PTSD. All right. So caring for the combat veterans, veterans are more likely to harm themselves or try to harm themselves. Combat veterans in particular may develop heart disease earlier than expected given their age. They may have higher incidence of type 2 diabetes and sustain a loss of brain gray matter. High cholesterol and hypertension are not uncommon after often undiagnosed and misdiagnosed. So another consideration for a combat veteran is higher incidence of traumatic brain injury or TBI sustained from trauma secondary to the explosion of an improvised explosive device. TBI may go undiagnosed because of its manifestations are similar to the symptoms of PTSD or because the patient downplays the symptoms. So when treating a combat veteran with PTSD, you're going to try to eliminate excess noise. Do not touch or do anything to the veteran without explanation. Diesel fumes sometimes can be a trigger for combat veterans because that's, that drove around in a lot. So returning combat veterans is a patient who will require a unique level of understanding, compassion. All right. So you want to make sure that you're careful of how you phrase your questioning. All right, so I got an emergency going on. I got to get off here. That is the end of it. There is, I don't, let's say the number for this one is 1, 2, 3, 4. Okay. The number is going to be 1, 2, 3, 4. There's not going to be a number to get on the test, but to do your checkoff sheet or your attendance sheet, it's going to be 1, 2, 3, 4. Okay. So I'm gonna go ahead and jet off here and figure out what's going on. And if anybody needs me, please do not hesitate to get a hold of me. And if anybody's got any questions or anything, send me an email or send me a message in Navigate. All right. It's good seeing y'all, and y'all have a good evening.